All right. Good evening, everybody. Thank you again for coming today. It's a new world we live in here with this coronavirus. We're trying something new with these webinars, these online learning sessions. So thank you again for coming. Really appreciate it. Just real quick before we begin, just a couple of things. As attendees, the audio has been muted and I can't see you. But obviously, if you have a question, we'd love to make this as interactive as possible. So there's a little Q&A feature located at the bottom of your screen. If you have a question, if you click on that, you can type a little question in there, and then I will see it and we'll answer it at the end. And if you don't have or if you have a question that's not answered during the official Q&A session, please give our office a call anytime. Happy to discuss and answer all the questions we can. So thank you again for joining us. And then also wanted to let you know we're going to record this and put it up on our website as well as our YouTube channel so that you can review it again. So again, tonight we're going to be talking about advances in hip and knee replacement, all about robotic surgery. Just a few quick disclosures, none of which are pertinent to this talk tonight. So just real quick, wanted to introduce myself. I'm Michael Morwood. I work at Atlantic Orthopaedics. My specialties are hip and knee replacement and trauma surgery. I did subspecialty fellowship training in both of those areas, and I specialize in hip and knee replacement and with robotic surgery, which is what the main focus of tonight's talk is going to be. So just a brief outline of what we're going to be discussing tonight. We're going to go through a little bit about understanding really what the fundamentals are regarding joint pain. We'll get into the treatment options, and then the main portion of the talk tonight will be about joint replacement surgery, especially with hip and knee robotic surgery. A little bit on recovery expectations, and then once again at the end we'll do a little Q&A. So please, we definitely would love to have your questions. If there's anything that comes up, want to make it as interactive as possible in this new format that we've got. So I'm going to start this presentation with a case. So this is a lady who came to see me, 59-year-old lady. She said she had left knee pain for many, many years. Kind of described this grinding type pain, aching pain, gnawing pain, very classic common symptoms of arthritis. Wakes her up at night and she can no longer walk around the block without pain. So here are the x-rays. As you can see, the left knee on the right side of the screen here, bone on bone arthritis. We'll get a little bit into this more specifically as the presentation goes along, but you can see just the knee looks angry, bone on bone arthritis, big bone spurs everywhere. Looking at it from the side, you have these big bone spurs back here. The knee is actually divoting itself into the tibia. It's so worn out, it's grinding away into the tibia. So this is incredibly painful. Looking under her kneecap, also same thing, you see a bunch of bone spurs. So she went on to have a robotic assisted total knee replacement. This is looking at it from the front. Again, we'll explain a little bit about what the mechanics of this knee replacement are a little bit later. This is looking at her from the side, underneath her kneecap. No bone on bone anymore. Arthritis is gone, and she's doing very, very well, is very happy. So you can imagine your joints are involved in almost every activity you do. A diseased or injured joint, hip and knee specifically, can definitely limit your ability to move and work. This is one of the most common causes of disability in the United States is joint pain. So common causes of joint pain, well, there's rheumatoid arthritis. That's one of the more common. That's an inflammatory arthritis. Typically, that's a hereditary thing, or you've at least had it since you were a child. Probably the most common form of arthritis that we see is osteoarthritis. This is a wear and tear arthritis. This is when the cartilage at the end of the femur or tibia, if we're talking about the knee, or at the top of the femur in terms of the hip, but that's when the cartilage is worn down. They're bone on bone. This is that grinding, painful arthritis during walking and during activities that you love to do. Then there's a post-traumatic arthritis, which I see sometimes in the trauma space. It's a less common form, but that's actually because of an injury to the joint, which then leads to a cascade of things that over time can lead to advanced arthritis. But regardless of the cause, it's a big burden on society. Arthritis affects nearly 54 million Americans, and that number is only increasing. We start every conversation about arthritis with non-surgical treatment. So we try to do everything we can without surgery first. Walking aids such as walkers, canes, crutches, heat and cold therapy can be very, very beneficial in terms of relief, especially for the knee. Physical therapy. A lot of times when your joints hurt, you favor the other extremity, so you take the pressure off the injured joint. This can lead to muscle atrophy, can lead to muscle weakness, and actually can do even more harm than good. So physical therapy is very important sometimes by retraining the muscles, retraining the posture, retraining the gait and how you walk to get your day-to-day activities back in better alignment. And then medicines by mouth, anti-inflammatory medicines like ibuprofen, Motrin, Aleve, and then even corticosteroid injections can also be very, very helpful. These are all part of our non-surgical treatment armamentarium that we try every single time before surgery. But when to consider joint replacement? So we'll get into kind of the heart of the talk with this. These are the questions that I actually ask every one of my patients before determining when is the right time. Because I'll tell you, one of the most common things I hear is, doc, when is it time for a knee replacement? Well, I'll tell you, is the joint pain affecting your ability to get a good night's sleep? Are you being woken up? Can you not find a comfortable position? Are you constantly tossing and turning, trying to put pillows between your legs because your knees and hips are hurting you too bad? How about, does the joint pain keep you from doing the things you love to do? Hey doc, I used to be able to play 18 holes of golf. Now I got to ride. I can't walk anymore. It's just too painful. I used to walk 5 blocks a day. Now I can walk 1. These are the things that I love to do. I can't do them anymore. That's a very common symptom of arthritis. Are you less active because of joint pain? Again, I used to go for a mile walk a day. Now it's down to just around the corner. I can barely get to the store. These are the issues that are being caused by my joint pain. And then how about your ability to get up and down stairs? My bedroom's on the 2nd floor. I have a hard time getting up the stairs to go to sleep. How about getting in and out of a low chair or in and out of the car? These are, again, things that when you start checking off these boxes, it's probably a reasonable time to consider a joint replacement. So we'll start with total hips, and then we'll go to total knees afterwards. But here's a total hip. So we'll start with the regular anatomy. So on the left-hand side of the screen, you see this is what a normal hip joint should look like, a ball and a socket. The femoral head is the ball, obviously. The socket is what's called the acetabulum. And they rub together with good, healthy, thick cartilage. Now, when that cartilage goes bad, we start thinking about arthritis. So you see on this side, the right side screen, the red, angry, irritated, inflamed joint where the cartilage is being lost, the bone-on-bone grinding, bone spurs can occur, and that's what an arthritic hip will do. This is an x-ray of what an arthritic hip looks like. So on the left side of the screen, here's the ball, there's the socket, there's space between the bones, that's where the cartilage is. And then on the right side of the screen, you see an arthritic hip. No cartilage, bone on bone. These are big cysts that are forming inside the bone because the bone is seeing a lot of increased pressure. There's basically a square peg in a round hole in this scenario. And that, again, is one of the most common causes of disability that we see in the United States, hip and knee arthritis. So joint replacement, total hip especially, how does it work? Here's a quick little animation, which I'll talk through the basics of hip replacement. So in a hip replacement, obviously, we go down to the joint itself. The diseased bone and cartilage is removed. The socket portion is resurfaced with a metal cap. There's a piece of plastic that goes inside, a pin that goes down the leg, and then finally either a metal or ceramic ball. The hip is brought back in, and that's the new hip joint. Those are the basic components of a total hip replacement. Once again, total hip replacement. Basically, it's just we're removing that diseased, damaged cartilage, diseased and damaged bone, but you keep your muscles, you keep your bone, the femur, the socket. It's just a resurfacing particularly. In the US alone, 300,000 hip replacements are performed, and this actually is estimated to grow to close to 750,000 hip replacements by the end of 2020. So again, it's a very big burden to society, and a lot of people are dealing with it. Again, here's just a schematic of the hip implants that we use. This is the metal cup, the ceramic or metal head, the pin that goes down the leg, and then the piece of plastic where the hip joint actually works. And this is what a hip x-ray looks like. So instead of that diseased bone-on-bone arthritis, you've got the pin down the leg, the resurfaced socket, and the metal ball. But let's talk about robotics, because this is the heart of the talk, I think. And we'll talk about total hip robotics first. So the MAKO robot, you might have heard of that term MAKO. That's a brand name of Stryker. Stryker developed, in conjunction with other companies, this MAKO robot, and this is how it works. So I'll begin with a case presentation, and I'll take you through a case of a robotic replacement. So this is a 55-year-old gentleman who came to see me complaining of significant right hip and groin pain. His chief complaint was, he said, I can't move my right leg from the gas to the brake without severe pain. It's affecting driving, one of the most basic things we do. And so here's his x-ray. We've now learned that hip arthritis is seen here on the right side of the screen. There's no space between those bones anymore. That's bone-on-bone arthritis, big bone spurs all over the place. This is incredibly painful, and you can imagine every time he moves that right leg side to side or walks on it, he gets this grinding, aching, gnawing type pain. So he elected to have a hip replacement, and this is how it works. The beginning of the robotic replacement actually isn't even in the OR. It's before we get into the operating room. One of the key tenets, and probably one of, I think, the most exciting pieces of technology that we have, is this personalized plan. It begins with a CT scan. So we're able to gain from this CT scan a 3D model of every patient's unique anatomy. I can tell exactly where their hip joint is in space. I can tell where it is in reference to other landmarks. And I use this 3D model to develop a plan to place my implants perfectly. And what do I mean by that? Well, here's our 3D model. Okay, and I'm able to spin this around, look in 3D space to see what's going on. The amount of information that we get from this is incredible. I'm able to see, as you can see down here on the right side, whether his leg is shorter or longer. 99% of the time, the leg becomes shorter than the other side because the cartilage that's lost allows that hip joint to drive itself up. So this patient actually had a 9mm leg length discrepancy. So he was about a centimeter short on that right side because of the cartilage loss. So I'm able to, even before we get in the operating room, know in my head, I've got to gain some length. I want to make his legs equal and perfect again. So where I place my implants is going to be relying on these numbers. Again, there's no guesswork. The best part about this is everything is determined and executed to perfection. And I take this 3D model and I start planning where I'm going to place my implants. I know exactly where I want it to be, and I can match up his native anatomy. And then I see where my implant is in terms of what the what's called inclination, but basically that's where the hip socket is in space, including the inclination inversion. I'm able to develop a plan, look exactly where his bone is, and place that implant to perfection. Here's this 3D model again, looking at where this implant is going to be. I can look and see, is this going to impinge on any other structures? Is there going to be soft tissue getting in the way? Am I going to be irritating soft tissue with where it's placed? I can tweak with it as much as I want to place the implant exactly where I want it to be in the safest position possible. Here's just looking at that 3D model again from the front, knowing exactly where my cup is going to be. I'm also able to look at that stem or that pin down the femur. So I see exactly what size it's going to be. Once I know what the size is, I can look at some other numbers, some other data, which tells me the anatomy of his thigh specifically. This number here, this femoral version, that changes for everybody. That has to do with kind of where the hip center is in space. And that changes for everybody, but yet I know this patient's exact anatomy. And here's what it's going to look like when I get everything done. This is before I'm even in the operating room. I can plan this patient's case and execute it to perfection. I know my leg lengths are then going to be equal based upon where everything is sitting. And then we finally get in the operating room. And this is what the operating room looks like with the robot. So the thing about the robot, it's actually not doing the surgery. I'm doing the surgery. I'm scrubbed in. I'm using all of the instruments. But what it is doing is it's using the plan that I've developed before getting in the OR. I'm now looking at the screen of my plan, and the robotic arm is able to come in and it tells me exactly where I'm going to put my implants to match my preoperative plan. So the beauty of the first tenet, which is the CT scan, matching up with the second tenet, which is intraoperative ability to measure and to place the implant perfectly, this is where it's made it up. So the robotic arm it comes in and it tells me and shows me in space exactly where I want that to match exactly what I want it to do. So no guesswork. And again, here it is. This is me in the operating room. I'm using the robotic arm. As you can see here, again, I'm pulling the trigger. I'm operating on the body, but I'm able to use that robot and it won't let me deviate from my plan. My plan is exactly what it will let me do. Once the patient's implants are in and trialed, I can see, well, where are we? Well, I'm actually 2 millimeters, a little bit longer than the opposite hip, so I can change that. I'm able to use the components in the operating room to get it exactly where I want it to be. I get final measurements that tell me I'm exactly where I want it to be. And then here's the post-operative x-ray. The cup portion is exactly where I wanted it. The leg lengths are perfect. The stem is fitting perfectly. And again, I think the beautiful thing about this technology is accuracy. There's no guesswork anymore. We're able to use these, develop a plan even before we get in the operating room and execute it to perfection. And that's, I think the most amazing thing of the technology. Muscle sparing approaches, you probably hear a lot about this. I do an anterior approach for most folks. This is a great operation. It's a slightly smaller incision. We do it through the front of the hip. We don't have to split any of the muscles. We can just move the muscles out of the way and then place our implants and then put it back in. Certainly we've seen great results with the anterior hip, quicker recovery, much less pain. For the right patient, it's a tremendous operation. Again, the direct anterior approach is what I'm talking about. Usually leaves the muscles undisturbed. Afterwards, there's not really any hip precautions in terms of what you can and cannot do in motion-wise. And then multiple studies have shown a quicker recovery, less need for post-operative therapy, and improved immediate pain relief. So that's just another, extra little benefit, I think, which for the right patient can go a long way. Just a little diagram of what we're talking about when we talk about anterior. You're making an incision on the front of the hip rather than the back of the hip. One more thing, wanted to just run through real quick. I hear this all the time. Well, hey doc, I'm 83 years old. My hip is terribly arthritic, but am I too old? Can I not get this operation? When I was in residency at Duke, there was a great study that came out that looked at the effects of total hip arthroplasty on physical functioning in the older population. Their conclusions after looking at the success rates were that seniors with arthritis who undergo hip replacement are twice as likely to show improvements in functioning and ability to care for themselves. Notably, there was no age limit seen on the benefits. So of course, it's not a minor operation. There's definitely risks and benefits to everything, but it's a conversation you should have if there's a indication for the surgery. It's not something that is completely not possible. It's certainly something that a conversation should be had because I think it can significantly benefit folks. So I think we'll probably keep going just to get to the knee section, and then we can get back to some questions. So let's jump into total knee. We talked about total hip, and now let's talk about total knee. Again, we'll kick it off with a case presentation. So here's a 50-year-old female came to see me, long-standing right knee pain. Her range of motion was 10 degrees to 110, so she was not able to get her leg straight, had about a 10-degree knee flexion contracture. And she said, my knee gives away randomly. I never know when it's going to happen. I'm afraid I'm going to fall. A very kind of classic picture of what we hear constantly. I'm afraid I'm going to fall. My knee pain comes, my knee gives out. So this is her knee. Again, we know now on the right side of the screen here, space between the bones is where the cartilage lives, but there's no cartilage left here anymore. This is just bone-on-bone arthritis. Again, from the side, there's just bone-on-bone. You can't see any space. Underneath the kneecap, we start seeing big bone spurs everywhere as well. So she undergoes a robotic-assisted total knee. Again, as you can see now, the leg is straight. Before, the leg was bent outwards almost 15 to 20 degrees. The leg is straight. The implants are fitting perfectly, and she's doing very, very well. Is incredibly happy with the result, and is no longer falling or having any pain. So what is a knee? I mean, a knee is a little bit different than a hip, of course. It's not a ball in a socket. There's multiple what we call compartments to the knee. We like to think about the inside, the outside, and then underneath the kneecap. But the same arthritis sort of symptoms occur when the cartilage gets lost, the bone-on-bone arthritis occurs, the menisci can get torn and beaten up and degenerative. Same sort of process. Again, a knee x-ray, we know, looking at the left side of the screen, the space between the bones, that's good, healthy, thick cartilage. There's no arthritis in there. And then we look at an arthritic knee. That's bone-on-bone, grinding arthritis, big bone spurs all over the place. And then the really dense white area is called subchondral sclerosis. So that occurs because the bone underneath is now seeing more stress than it's used to. Usually has cartilage there to cushion and to balance the knee, but now it's seeing much more stress. And then one note here, every 1 pound is between 4 to 7 pounds of pressure off of the knee joint. So even a 10-pound weight loss can be beneficial to up to 70 pounds of pressure off the knee. So it's an incredible benefit to be as healthy as possible and to be as physically active and fit. Here's just a very basic kind of video diagram again of what a total knee replacement is. Now I'll tell you the difference between a total knee and a total hip. A lot of folks it's a little bit of a misnomer. They think a knee replacement is where we take your knee, we throw it out, we put a new knee in. It's actually a little bit different. It's basically just a resurfacing. So we make very precise fine cuts and then place a metal cap on both the tibia and the femur. And then there's a piece of plastic that goes in between that your knee moves on. Almost like a dentist puts a crown on a tooth. It's purely just a resurfacing of those bony surfaces that used to have cartilage on it, but are now not. One benefit to the knee being compartmentalized, like we were talking with the medial compartment or the inside, the outside compartment, and then underneath the kneecap, is sometimes folks can be candidates for partial knee replacement. So when we talk about a partial versus a total, you can see here on the left screen, this is a partial knee replacement. Only the inside portion has been resurfaced. On the right side of the screen, this is a total knee replacement. Both compartments of the femur have been resurfaced, and then underneath the kneecap as well. The benefit to the partial knee replacement can be many, and that's probably a talk in and of itself. But for the right patient and the right scenario, a partial knee replacement can be a quicker recovery, a smaller incision, and getting back to more normal activities quicker, even, for the right patient. Total knee replacement, great operation, and it's necessary when all the compartments are affected. But the benefit of a partial knee replacement, again, can be quite dramatic. The figure down at the bottom of this screen tells us that 600,000 knee replacements are performed each year in the US. And once again, by 2030, this is expected to grow to over 1.5 million knee replacements every year in the United States. So here again are the types of partial knee replacement. So this is just a little cartoon kind of describing what I was talking about. If you look up to the upper left hand of the screen, you see this white shiny cartilage with no damaged areas, but this is just a medial compartment or an inside compartment arthritis. You see it's damaged, it's red, it's irritated underlying bone. Again, you can have the same thing in the outside or lateral compartment, underneath the kneecap only, or even underneath the kneecap and one of the other compartments. And then if you look at the bottom, that shows what the implant would be. So if it's just the inside, you get the resurfacing here, just the outside, resurfacing, and etc. This is what those knee implants look like in an actual format here. Here's this metal resurfacing cap, and a piece of plastic in between. Left side of the screen, again, is a partial knee replacement. Right side of the screen is what a total knee replacement looks like. And these are what the x-rays of those look like. So the inside medial compartment, partial knee replacement. Again, you see intact, healthy cartilage here on the outside of the knee. And then we go to this side, and this is a total knee replacement. This is when you resurface all of the surfaces of the knee. How about MAKO robotics for the knee? This is actually where it began. So the MAKO robot began with partial knee replacements. then moved on to total knee replacement and total hip replacement. The robot has been around for over 14 years, has 145 plus peer-reviewed studies. There's over 850 systems, and this is growing, installed across 26 countries, 1,000 plus patents, and then 300,000 MAKO procedures have been performed, and this is obviously growing tremendously with this technology. So how does it work? Let's hope this, I'm going to bump up the sound here. This is a video with some sound.
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the MAKO system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the MAKO system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
I hope everybody could hear that. So that's a great video, just kind of giving the overall picture of what a knee replacement with a MAKO robotic arm-assisted surgery would be. So I broke it down into kind of 4 tenets. Again, it's similar to the hip, but we'll go through these individually. Begins before I even get into the operating room. The CT scan is evaluated, it's reviewed, and then we develop a personalized surgical plan to match the patient's anatomy. Everybody's a little bit different. This is, I think, the bread and butter of the system. In the operating room, then, the robotic arm is brought in, and I'm able to remove only what I want to remove. There's no guesswork. I'm removing exactly what I want to be able to place my implants in the exact correct position. They fit the bone perfectly, and they're mated perfectly to the individual patient anatomy. The next wonderful piece of technology or tenet of this system is intraoperative range of motion assessment. Once I remove the bone, I'm able to get a real-time feedback in terms of how the knee is balanced, how the knee is working, what is the flexion, what is the extension, and I can make any kind of changes or any kind of assessments to this to be able to, again, get a perfectly natively functioning knee. Now, again, a total knee is not a knee that you had when you were 15 years old, but again, the idea is that every knee is a little bit different. Every knee is unique to each patient, and the ability to make a plan for that patient's anatomy, remove exactly and only what I want, place the implants, check the stability, check the range of motion, and check the entire function of the knee, and then I'm able to place the implants exactly where I want them to be. So for me, I love the idea of no guesswork. There's no manual instrumentation, there's no eyeballing, there's no guessing. It's exactly what I planned to implant placement. And this has been studied multiple times in multiple studies. The MAKO total knee itself has been shown to have actually lower pain scores than those who received a conventional joint replacement. I think a lot of this has to do with we don't have to do as much soft tissue dissection anymore. There used to be a lot of kind of soft tissue stripping to be able to get the knee balanced, but now we're able to make such precise cuts with the robotic arm. We don't have to do as much soft tissue rebalancing and stripping at all. The partial knee replacement, again, I think this is a tremendous technology for partial knee replacement. Partial knees have been studied, and the MAKO partial knee has been shown to have less pain, shorter hospital stay, and quicker recovery. And then the total hip, the replication of the feeling of a normal hip, the offset, the leg length, the placement of the implants so there's no soft tissue impingement. These are all things that contribute to having a more normally feeling, functioning hip. And I think the MAKO system certainly allows that to be as good as we can possibly get it. So my last slide, I wanted to finish with this picture. So my goal as a surgeon is to hit a bullseye every single time. No guesswork, no outliers. Every patient deserves the best operation every single time. And I think this technology is such that it allows us to have a bullseye every single time. So once again, I want to thank everybody for listening and hope we learned some things. We do have some questions already, so I'm going to pull those up. If anybody has any questions they've been thinking about, feel free to put them on the Q&A page. All right. Can you guys hear me and see me? Okay. So first question that came in, how do you know when it's time for a knee or hip replacement? I think, again, a great question. Knee and hip replacements are never anything you have to have. The one really important thing I like to tell people is not something I tell you you have to have. When the time comes, you tell me it's time. And the way I help people make that decision is we go through that same, rundown of questions. Is it waking you up at night? Is it limiting the things you love to do? Are you no longer able to play with your kids and grandkids? Can you not, used to play golf, can't play golf. Used to play tennis, can't play tennis. My knee hurts every time I ski. Those are things that we really start saying, yeah, this could be a significant benefit for you. Is there a point at which either a hip or knee cannot be replaced because of level of damage? Another good question that I get this a lot. The short answer is no. The knee and hip can be replaced. Technically, from a surgical standpoint, it certainly becomes harder and harder the more deformity. And a lot of times the postoperative recovery for patients is harder and harder. You can imagine the more, let's take a knee, for example, the more the knee becomes arthritic, the more it won't want to bend. And so if you come in with full range of motion before the operation, you'll have full range of motion after. The more that the knee becomes stiff and doesn't want to bend, it's just that much harder to get those muscles to recover and recoup postoperatively. So short answer, no, there's not a point at which it can't be done, but the longer answer is that the sooner you get it done, most of the time, the better the outcome and at least the easier in terms of recovery. Next question, can you operate on both knees during the same procedure? Again, short answer is yes, but I almost never recommend it, and here's why. Most of the time, in my experience, when people have, let's say, two bad knees, if you do one, and that one is then now a good leg to stand on, you can take a little pressure off the other one, and the other one even starts feeling a little bit better. You can delay that surgery for as long as you can to get the most time out of it as you can. The other reason is it's a pretty big hit to the system to have both knees operated on. The recovery is much more challenging. The hit to the system is a little bit more challenging. There have been studies that have looked at this. There are some increased complications in terms of health from a cardiovascular standpoint. So I always like to not do both. You can, it is possible. I have done both. But usually I like to recommend at least 4 to 6 weeks between both knees. The next question, how far in advance is a joint replacement planned using the MAKO the day before or weeks before? Again, great question. Usually is within a week or 10 days you get a CT scan. The reason being is because the intraoperative findings need to match what the scan shows us. So, things can change. We don't want to get something 6 months in advance because disease will continue to deteriorate. Big bone spurs can happen, which the robot won't be able to mate between what the scan was and what I'm seeing in the operating room. So typically, we schedule the replacement. The scan is done 7 to 10 days or so before the operation. That gives us time to review the scan, review the plan, and get that plan executed. So I think that's the end of the questions. You guys, we're good on questions? So again, I wanted to say thank you so much. I appreciate this. This is something new we're starting here with these Zoom webinars. I'd love to continue to do them as long as there's interest, and please keep the questions coming. Once again, I think this is going to be recorded, and we'll put it up on the website as well as the YouTube channel. So please feel free to call if you need anything, or we'd be happy to take a look. Hope you have a great night. Thank you so much.